Okay, hello, welcome everyone to the Freedom Hub's presentation of the Free Market Cash Patient. I'm your host today, Jeff Cantor, along with my co-host, Charles Froman. We are also sponsored by a variety of organizations, and we are the Disruptors Corner here for sure, so I definitely wanted you to be aware of that side of things. And we are recording all of these for posterity, so just as you can see, these are the various channels that are released over the weekend, so every Monday morning you can come to any of these that you prefer, and you'll be able to see them here. Just to give you a little taste, this is the particular one that's on BitChute, you'll notice, and this is, it turns out I had a video that got banned off YouTube, so we've made it say so, and I went from like, you know, dozens of views to hundreds to now over to like almost 800 and stuff. And really this guy's now been vindicated because he was explaining how hydroxychloroquine functions and so on, and he took a big hit for that. We're also sponsored by Freedom Hub, and also give you a little flavor too, we've also uncovered a remarkable program for the most bioactive product in the hemp field out there. And here they're offering a special discount, which normally it's like 5 or maybe 10, but here they're giving 15% off. This is what their site looks like. So you want to check that out too. So, but let's talk about for today for a minute here, and let's discuss what's going on and who we've got visiting with us. Let me open that up for a minute. So here we've got Mr. Ralph Weber himself, who's the founder of Medibid, been around for a long time in this industry from one side of it to the other. And he's also written some great books for sure. And also some new things that are cooking that he's going to want to bring us up to speed on. And I'm going to let him have control of the screen so he can kind of show us some of the materials that he's got.
So I have, first of all, I've lived in 5 countries on 3 continents. I was born in Canada. I'm German. I grew up in Thailand, in Nepal, in Germany. I returned to Canada, living in Houston now. So I've seen many healthcare systems throughout the world. Eastern medicine, Western medicine, single payer, 2-tier government medicine, private medicine. I've seen it all. I've seen what works, what doesn't. I've seen the good, the bad, and the ugly. Nobody, in my opinion, has the perfect system. It's not out there. So what we try to do, and a lot of people out there try to take the status quo and tweak it. They just try to tweak it. Just, you know, let's fix it by 2 or 3 degrees. In my opinion, so badly broken, you can't tweak it. You just got to tear it down to the ground and start from scratch. I have a lot of friends, colleagues that tell me all you have to do is, you know, make the employees consumers. And I agree with that. A lot of people say, all you need is transparency. I agree that transparency is important, but I know you need more than just transparency. As a matter of fact, just transparency will increase costs, and I'll talk about that during my presentation. So you need a number of things. Okay, number one, there's only one person in the U.S. that can control healthcare costs, and our population is what? 328 million, there's only one person that can control it. No, it's not the president. It's you, the consumer, you, the patient, you, the consumer of healthcare services. It's not Blue Cross. It's not Medicare. It's not the president. It's not Congress. It's nobody but you. And here's why. When you walk into Best Buy to buy a TV, you're the one that can say yes or no. When you go to Expedia.com to book a flight, you're the one that can say no. When you go to Priceline, you're the one that can say no. So in healthcare, we have a system in this country that's like no other country. It's a third-party payer system. It's privatized, even though the government pays more than half of the healthcare costs through Medicare, Medicaid, and the VA. But with the third-party payer system, if you can see my fingers here, okay, pretend this is the patient, this is the doctor or hospital, and right here is the patient. Or sorry, the payer, okay? So there's no direct relationship between the buyer and the seller. There's no direct relationship. There's a relationship to the seller and the payer, There's a relationship to the consumer and the payer, but there's nothing here. Okay? That is the problem. Now, Jeff, I have a pop quiz for you. In Milton Friedman's words, how many kinds of money are there?
That's a good question. I'm not sure what his response to that was. You've got me there.
Two. Two kinds of money. Your money and my money. How many ways are there to spend money?
Well, there's a multitude of ways, but I know there's a special answer, and I'm not sure on that one either.
4. You spending your money, me spending my money, me spending your money, and you spending my money. Okay? So those economic principles, if you really, internalize them, that is really the essence of the true economy, and it can be applied to healthcare. When I go to a doctor and I have a Blue Cross health plan, I'm not spending my money. I'm spending Blue Cross's money or my employer's money. Okay, so I'm spending your money. Okay, because you also have a Blue Cross plan, so your premium pays and I get to spend that, or the employer, or whatever. Okay, I'm not spending my money. Now, a lot of people say with transparency, that will help. Once you figure out how much these hospitals are charging, you're not going to go for it. I disagree with that. Once I'm past my deductible, I don't care. I don't care if they charge Blue Cross $5,000 or $5 million. I really don't. As a matter of fact, sometimes I get a little bit more excited when I find out my hospital is charging Blue Cross $5 million because I think, wow, I must be getting like the best treatment in the world. So this is really good. So in some cases, I might actually go to a higher cost provider given transparency. Because I'm not spending my money, I have, no skin in the game. And we all know that expression, right, Jeff? Skin in the game. So people tell me, well, all we need is a $10,000 deductible health plan and transparency. Well, the number of people that spend $10,000 or less on healthcare in America is 97 or 98%, okay, of people spend $10,000 per year or less. 65% of people in America spend $1,000 or less. 94% of people in America spend $6,000 or less. The problem is that all of those people put together, let's use simple terms. I apologize. I just had something pop up on the screen here, okay? In simple terms, the 80-20 rule. 20% of the people spend 80% of the costs, okay? Now, those people are through their deductible by February 1st. Those are the people that spend 80% of the healthcare costs. And when we're trying to control 80% of the population that spend 20% of the cost, even if you cut their spending in half, it's only going to save 10% of the total. Whereas those 20%, that's where we need to have some controls, okay? So in simple terms, that is where we as Medibid focus, okay? Now, how do we work with employers? Now, ranges of allowable charges this is for a knee replacement in the city of Oklahoma City. Medicare pays $14,628. Hospital A, which has a PPO in-network contract with a big insurance carrier, gets just under $17,000. Hospital B, right across the road, gets almost $96,000 for the exact same procedure. Now, this is interesting. Our average price, now, Jeff, this was 3 years ago, and my screen is kind of blocking back here. What is it? $18,886. That was our average price 3 years ago. Today, it's $17,341. So our average price has gone down by 10% since I created these slides, okay? So if you look at our average price, you'll see, okay, that's interesting. So, and I have another slide that goes deeper into this. We've analyzed claims, $2.5 billion, actually $2.6 billion in bill charges for the state of Tennessee. What we have done is we've measured, and I'm not sure if you can see my mouse on the screen here, the allowable charges to bill charges, okay, 40% ratio. What we'll see is this particular provider, and let me just move my control panel off here so I can see it. There we go. So their medical rating is 2 stars out of 5. Now this medical rating is done by CMS every year. They survey, every hospital has to fill out a very long survey about costs and quality. Every time a patient gets dropped off a gurney, their mortality rate, their morbidity rate, okay? So their mortality is below national, their safety is below national, their readmissions is below national, their effectiveness is about average. Patient experience is good, okay? I'm guessing that they didn't interview the patients that didn't make it. So the ones that made it said, yeah, it's okay. Now, if you look here, I'm going to have to put on my glasses here for half a second. The charges of this hospital to the health plan were $56 million. The market costs of these procedures were 1/10 of that, okay? The lines of claim were 72,000 and the paid claims were 22 million. Again, the market value was 5 million. So this is what came up in our claims analysis. Here's another one. This is removal of one knee cartilage using an endoscope. Now, as you can see, and Jeff, can you see my mouse when I'm pointing at the screen here?
Yes, I do, where you're showing the bar graph.
Okay, yeah, great. So what you can see here is the green, these are the baseline costs. And this is the median charge all along the green. Now, this is only taken the top, 1/3 or so. The yellow is the tolerance. So what we've said is if whatever the median charge is, the tolerance is double. We'll pay up to double of the median charges. The red, those are simply excessive charges. So what you can see is here at the top, really excessive, crazy charges. Okay, so obviously some of the problems with healthcare is there's a lack of full transparency. And I'm going to add something huge. There's a lack of full transparency and competition in both the cost and the quality of healthcare. Providers are essentially prohibited from competing in the status quo. There are no market forces. The upfront costs are too high, meaning the employee's portion of the premium is too high. The employee out-of-pocket costs are too high. The opportunity is we're an online solution, obviously, where you actually get to make a request and up to 120,000 providers will submit a bid on that request. That reduces employer payer costs between 38 and 65%. It lowers member out-of-pocket spending and it increases employee choice and quality. The way we work is really pretty simple, okay? So the patient creates a profile and submits a request. Automatically, our system contacts doctors and facilities, 120,000 in 14 countries. The doctors review the request and submit bids. The facilities also review the request and submit the bids. And as they post their bids, you get to see their quality rating, 3 stars, 5 stars, 5 stars, 2 stars, 4 stars, and you get to see their price. You get to see which one is an individual doctor, which one is a facility. And the doctors, these are the doctors, these are the hospitals, the patient reviews the bids and chooses one, okay, based on his or her opinion of value. So instead of the insurance company saying these people are preferred providers or in network, the patient has complete control over the yes or no decision.
Alf, let me ask you one quick question here before you continue. To be back up to before that first slide there where the person's submitting the request, where did the request come from? Did they just go to a doctor that wrote a prescription, or what is the origination of the request this patient's submitting? Or do they just say, hey, I just want to get surgery, and they just arbitrarily decide by themselves?
Either or.
Okay.
Usually they go to their doctor, hey, doc, my knee hurts. Well, let's get you an MRI. They get an MRI, and the doctor says, hey, you know what? The radiologist says you need a knee replacement. Oh, okay. Then they make a request. Okay, a lot of our employer groups, and we have about 83 groups of employers, about 400,000 users on our system, they make a request. And we're going to talk about the inverse correlation between cost and quality in just a few minutes. But they make a request, and then the doctors and hospitals respond to it. Now, this slide, Jeff, is a reuse of the slide before with a little bit of a twist here, okay? Now, we showed you this part. Now, there's a new line on this chart, okay? This is called reference-based pricing. What reference-based pricing does is we use a reference. Now, there are a lot of different ways to do reference-based pricing. What we do is Medicare plus a margin. Now, over the last 3 years, for $225 million worth of medical care, our average bid was 108% of Medicare, 108. But let's just use 150%. Again, this slide is 3 years old. Charges 3 years ago were a lot higher than they are today. Not for Blue Cross, but they were for this company. We had as a matter of fact, we have a small company in Houston, 214 employees. We just did their renewal. They had about 80 people on the health plan. We took over their plan from one of the big insurance companies about a year ago. They were paying $788,000 a year. We projected savings of $249,000. Now that we are 11 months into the contract year, they've actually saved. We projected savings of $249,000. It's actually going to be in excess of $290,000. And we just did their renewal, and for next year, they're getting a decrease of 7.1%. Okay? So not only did we save the money in the first year, their renewal, they're getting a decrease. Now, what reference-based pricing does is, as you saw, I'm going to go back here, you see you've got this big orange bar. Oops, going the wrong way here. You've got this big orange bar, and we just cut off anything above the margin plus 50%, okay? And we just say, here's what we'll pay you, whatever Medicare pays plus 50%, and that's it. And like I said, with our average bid being 150%, there are a lot of providers in that range, okay? So what we do is we get rid of those with excess charges. Now, some libertarians will argue that that's price control. No. It's not. It's cost control. There's a huge difference. If you send your employee on a business trip and they stay in the Ritz-Carlton, as a business owner, you're not going to pay that. You're not telling the Ritz-Carlton they can't charge $500 a night. You're not saying that. You're just saying to your employee, I'm not going to pay that. You want to pay? Pay the difference. That's fine. Pay the extra $350, but I'm not paying. So that's all it does. Okay? So in the beginning, I said, how do we make the consumer the buyer? How do we make them a true consumer? For those that are spending small dollars under the deductible, very, very easy. Okay, within the deductible, they are to some extent a consumer. But if you tell them the plan is only going to pay what Medicare pays plus a certain margin, and any charges above that, you're going to have to be responsible for, then they become a consumer. Because then all of a sudden, instead of being carte blanche, payer's going to pay whatever the provider charges. Now they actually have limits. Okay, so I told you that we would talk about the inverse correlation between cost and quality. So let's take two knee surgeons. Okay, this one is an experienced surgeon. He does about 500 knee replacements every year. His time in the operating room is about 25 minutes on a knee replacement, and that means you're under anesthesia for about 30 minutes. Nights in the hospital, 0. Now, the 4 main components of cost on a hospital-based procedure are the physician fees, time in the OR, because hospitals bill by time under anesthesia, because anesthesiologists also bill by time, and nights in the hospital. Okay, so the charges on an experienced surgeon are this. Cost might be $35,000. Outcomes, high quality. Quality up, cost down. Now we have an inexperienced surgeon. Let me just move this over. Okay, inexperienced surgeon performs 2 procedures a year. Time in the operating room might be an hour and 45 minutes. Time under anesthesia, a couple hours. Nights in the hospital. Once you're under anesthesia for that long, the hospital is going to say, you need to stay in for a night or two for observation. Cost could be $85,000. Outcomes, 2 stars. Now, if we add transparency to a health plan and we say, Jeff, your deductible and out-of-pocket maximum is $5,000. Both of these are well in excess of $5,000. If we only showed you, we showed you nothing but one has charges of $35,000, one has charges of $85,000, a lot of people would say, well, I want to go to the hospital that has costs of $85,000 because that's got to be higher quality. In fact, it's very often lower quality, and we have studied, like I said, billions and billions of dollars of claims, and we have found consistently that to be the case. So for some employers, what they like to do with us is called a bolt-on plan. So we start by analyzing the claims. We create a bolt-on plans for the target areas where they're not spending money efficiently. We develop a plan that has no deductibles, just copays, and sometimes reverse copays. And then we train the staff how to use these plans. What we often do is a cash rewards program. If you go to a cost-effective provider, we'll send you a $100 Visa gift card or $500 or $1,000, okay, just for making cost-effective choices. So these kinds of plans for some large employers, that way they can stay with the insurance company they're choosing and just use us for those inefficient claims. So over the last 3 years, our results indicate that for some small groups, we have reduced their costs by over 2/3 while reducing out-of-pocket costs. Now that client I told you about at the beginning with 214 employees, by the way, just so you know, we reduced their deductible from $3,500 to $0. Okay, we completely eliminated their deductible. I talk to people all the time that says, oh, we need higher deductibles, higher deductibles. In my experience, higher deductibles increase spending. Lower deductibles decrease spending. Okay, we've proven it with thousands and thousands and thousands of millions of claims. We had one large group where we have saved over 81% versus bill charges and 54% versus Healthcare Blue Book Fair Price. Healthcare Blue Book is a great company. They give a really good benchmark for what insurance companies pay, and we saved this group 54% versus what Healthcare Blue Book feels is a fair price. So our engagement has increased by 329%, while the average procedure cost is down 27%. Our target price, you know, as I said earlier, our average median cost is 108% of Medicare. Our target is 82% of Medicare. You're not always going to get the target, but that's 1/3 of our providers charge that. So we have, you know, basically, you know, you said the word earlier, disruptive. We are very disruptive to the status quo. There are no preferred provider network restrictions. Pricing is just for you, transparent value. And sometimes crossing a state line for medical care can save you money. And we completely eliminate the middleman. Some of our clients have posted testimonials. This is a client, his name is Perry, and he was very happy. We saved him $49,000 on the hip replacement. This is another client, Regina. At first, and she was honest with us, she said, at first, I was really resentful that I had to post a claim and look at bids, like, you know, that kind of cheapens healthcare. Those were her words. But then when she went through that, she said, and I love this quote, we were clinging on to a familiar broken system. So what we've done is we've reduced healthcare costs for employers by 38%, at the same time reducing out-of-pocket costs for employees by creating a competitive bidding platform. We create direct contracting per episode of care, provide access to doctors and treatments not only in the U.S. but in 14 countries, and second opinions are also built in. So that is, in a nutshell, I just want to give that overview and then sort of open it up to either, a discussion between you and I, Jeff, or any questions I'm happy to address.
Fantastic. That was quite good. And as you can see, it's kind of a commonsensical, simplistic idea, but obviously it yields great results. The question I would have is, and anyone that has a question, please just raise your hand, then I'll unmute you so we'll kind of keep our background down to a dull roar. Let's say I'm just a private person. I'm not with one of these kind of groups or companies like you were describing, and I find this Medibid and I need that knee surgery. How do you coordinate with my insurance? My doctor said, hey, you need that surgery, and then I find you and it looks much better, but I do have insurance. Can I use it, or how does that work?
Yes, you can use it. Now, if you want to use the network allowable charges, okay, so actually let me back up. If the cost exceeds your deductible and you want the network deductible, which is lower, the in-network deductible, because the out-of-network deductible is usually twice as high, they may not apply that, or they might force the doctor to charge the network charges, which is going to be higher than the competitive cash price. If you're under the deductible, then, we are always going to save you money. Not always. Most of the time we're going to save you money. We've had a lot of people that had insurance plans with some of the big insurance companies, and, we've saved them on simple procedures like colonoscopies. One patient had to pay $6,600 out of pocket. We got it for them for $875. So even with an insurance plan, we often save money just by getting that direct price, that competitive price.
Sorry about that. I had myself muted there for a minute. Kathy, I see you've got your hand up.
Yes, I do. How does a doctor get involved with your group? How does he get his price or bids on there? Or does someone just go in and they look at all the doctors and ask for a bid? How does that all work?
Yeah, so we want doctors that are interested in, providing direct pay prices. We have employer groups that work with us, healthcare sharing ministries that work with us, people from Canada on waiting lists, uninsured people under the deductible. So we're always looking for physicians. Send us an email, give us a call. We're happy to go over with you how the program works. We're always looking for good doctors. So you can email us at info@medibid.com, and we'll have somebody from provider relations get in touch with you.
Okay, and you can, and people can possibly do like a carve out from their insurance. Yeah. And the broken plan that I spoke about is like a carve out from your insurance. So we carve out treatment procedures, something that was imaging, orthopedic, specialty medications. We carve out just those procedures and make them more efficient than they usually are within your insurance plan. Okay, thank you.
You're welcome.
Bob, I see you've got your hand up.
Here.
There you are.
Can you hear me?
Yes.
Great. Well, that was great. And I have some comments, mostly praise, and I'm very impressed with what you're doing. But I also, I'm a big fan of reference-based pricing. But there's a couple of inherent potential conflicts of interest I just want to bring up. But first, I did want to say that I'm a big fan of reference-based pricing. I think that you have a unique twist I think your international angles, are great, and I'd like to talk offline of becoming a reseller for your product. So I'm a big fan already. On the other hand, yes, you're welcome. On the other hand, I've been kind of studying the whole problem with healthcare in the U.S., and I believe it's really a 1-2 punch to solve it. You're the second punch is once someone needs an expensive ologist or specialist, we have to stop self-insured companies have to stop getting hosed by the untransparent, system, right? But I think an equally big problem is a good way. I didn't make this up, but a good way of putting it is to restore Goldilocks medicine. In the early 80s, in the U.S., there was a 1-to-1 ratio of primary care doctors to specialists. And that remains the ratio in Europe, in Canada, and all the other countries that you've been to. It's still a 1-to-1 ratio where it's kind of an even Steven thing. But in this country, over those 35, 40 years, it's now a 2-to-1 ratio of specialists to primary care doctors. And so what's happened, and a lot of those primary care doctors now work for hospitals who are just using them to throw people too early and too often to specialty care. So if you use that knee cartilage replacement slide, right? If the primary care doctors say, why don't we try this? Let's lose 30 pounds. And if that doesn't work, let's try physical therapy, personal training. And then as a last resort, I'll send you to a surgeon, right? So that would become Goldilocks medicine is the only thing worse than sending too few people to specialists would be too many. And you get right in the middle. So we've lost that. Then the second wave of defense is if you send someone to a surgery center of excellence like Mayo or Cleveland Clinic, all the doctors are on salary. They do surgeries, but they also do second opinion consultations. And they're trained to treat every patient as if it was their favorite Aunt Sally coming in. So what they do is they turn away 25% or so of all new patients. They're saying, I know you're, and so the big savings to the company from a surgery center of excellence with salaried, not pay per, fee-for-service surgeons is that. So you're like a third wave of, now if you really do need the surgery, let's make sure it's as least expensive as possible. But because you're paid probably, I'm speculating that you're paid on a percent of savings, if the Goldilocks medicine prevents the patient from ever even coming to the surgery center of excellence, or the surgery center of excellence sends them home, you get nothing. So do you have an inherent conflict of interest to hope that, that meniscus surgery makes it to your provider and then you're saving or not? Do you have some way of rationalizing that you really hope that you see less claims as well?
All very, very, very good comments, Bob. I appreciate it. Let's start with your last comment about the charges. We have 3 ways that we can charge an employer group. One is a per employee per month fee, and that way we don't have a dog in the fight. Okay, we're just expediting their requests. Second one is a percent of savings. Okay, and the third one is a hybrid between the 2 methods. So we always go over all of the different methods available in terms of charges, and then they pick the one that makes the most sense to them. Talking about the Mayo Clinic, I'm sure you're familiar with the study that showed that 88% of the time, Mayo Clinic actually did this study, 88% of the time when somebody looks for a second opinion, the original diagnosis is overturned or modified. And a third of the time, an unneeded surgery is averted. So we're all about reducing costs for the employers, okay? Whether that is doing a procedure for 80% less or eliminating that procedure, and in other words, 100% less. That's what we're all about is, reducing costs. When you make a request, let's say for a knee replacement, for example, you might upload your X-ray or MRI or whatever, And you're going to get potentially, now we do have 120,000 providers, but they're not 120 orthopedic surgeons. But you might get, tens of thousands of orthopedic surgeons that potentially can look at your request. You're going to get people saying, well, I'll do a knee replacement for, $17,000. You're going to get other orthopedic surgeons saying, hey, I looked at your x-rays and I don't see bone on bone. The plicas are in good shape. I don't think you need a knee replacement. I think you need a knee scope, or maybe some PT, or maybe some prolotherapy. So there's a built-in inherent, second opinion that they often offer. We often are able to, and I'm partly addressing that question that popped up by text here a couple of minutes ago, because it ties into what you were saying, Bob. We often will get somebody saying, here's what I need. We will sometimes get the insurance company or the third-party payer to pay directly. Just today, we had a patient, and I forget what the procedure was. They were quoted over $50,000 for the facility charge alone. We had the whole thing done for just over $9,000, and the payer paid directly at the time of service. So we saved them over $40,000, probably about 50 or 60. So getting them to pay direct is a huge part of what we do as well. Getting them to get a second opinion also helps, because then they see firsthand, what the other alternatives are.
Very good.
Does that address all of your questions, Bob, or was there anything else that I missed? You did
Yes. Oh, am I unmuted?
You're unmuted.
No.
Yes. So yes, you did. I was trying. The fact that you are focused on the total cost reduction of the population, for surgeries or whatever, and not just saving for individual surgeries. You're looking at the overall spend, and you're willing to be incentivized. That means you don't have a conflict of interest. So I definitely want to meet with you offline sometime. So I sent you a LinkedIn invite, so please accept it.
Okay. I will. Thank you.
All right, and see the benefits of trying to stirs the pot here on this show, so that's great. Appreciate that. Paul, I see you've got your hand up.
Yeah, it's a great presentation. I think that what your service offers is really one of the keystones, to healthcare reform, and just, getting the best out of the free market healthcare system. So my praise goes out to you. The next, I think, big wave in the free market healthcare sector, I think, is going to come out of the cost sharing platforms, and you kind of touched on that a bit. It sounds like you're working with those guys like MediShare, Sedera. What, if I can ask, is your utilization with them in terms of how much of your market is from that sector?
Actually, a fairly large segment, and we do work with many of them. MediShare, of course, uses an insurance network for their patients. They use the PHCS multi-plan, so their charges tend to be a little bit higher. But most of the other healthcare sharing entities don't use an insurance network, so that means the members can really save money. Sometimes it's hard to incentivize them, because what they would have to pay staying locally might be as low as $300 or $500, and they don't see the justification to travel to save that money. They don't always have to travel. We always get them local options. But sometimes the centers of excellence, the best quality and the lowest cost, means they might have to drive an hour. But when I talk to employees, when I do an employee meeting for an employer health plan, I ask them, if you were going to buy a 65-inch TV, would you just call Best Buy and say, hey, send me a 65-inch TV and the invoice? No, they wouldn't. They would never do that. They would look at Best Buy, Costco, Sam's Club, Walmart, Amazon, They would study the quality. They would decide whether they want a Samsung or a Sony or an LG or whatever. And then they make the purchase. And if they have to drive an hour and a half to save $800, they would probably do that. We need to do the same with our healthcare. When there's a third-party payer, whether it's a healthcare sharing entity or an insurance company or a self-funded employer plan, it's sometimes hard to incentivize the employee because they're not the consumers. The health plan is the consumer. So we like to talk to them about incentives, which is why reference-based pricing, I agree with many of the criticisms that the Medicare price isn't necessarily a great benchmark, and even if you had 20, 30, or 40%, it's not a great benchmark, but it's one of the better ones that we have. The point is that it caps it, and then it gives an incentive for somebody to find something more cost-effective.
I was going to say one thing about that Medicare, at least it's a list, because there's like prices are all over the map. At least they sort of like put everything on a piece of paper, so you got at least something to base your markup or markdown from. So there you go.
Exactly.
You know,
Yeah.
as lousy as it is. Kishore, I see your hands up. Or you there, you might have yourself muted.
All right, so I believe I'm unmuted now.
You are.
Okay, so I have two questions, and both are related to cost reduction. The first is about regional monopolies. And from what I know, in most places, there are only one or two providers. And in some cases, the entire state has only one provider or the same network, maybe not a single provider, but the same network. So how do you reduce cost in that context, assuming that most people want to get their treatment within the region? And the second question is about the use of critical care insurance, which hands out a fixed amount of money should you get an illness like cancer. And I'm curious why its utilization is virtually none. I just came to know about it while reading somewhere, and it sort of struck me like, how come we don't know about it? And it seems like its utilization is very low. And I would think that the costs would go down hugely if there's a use. So help me understand what's going on. I mean, why is it that such a handy tool is not being used? That's the second question. And the first one is, how do you even reduce costs when on the supply side you have restricted choice?
Mm-hmm. Okay, perfect questions. There's a city in Texas called Abilene, Texas. There's a big air base there. It's miles and miles and miles. It's 95 miles from Dallas, and just as far, it's the middle of nowhere. It really, literally is the middle of nowhere. I had an employer say, I don't want my employees to travel any more than 25 miles. And they had a lot of employees in Abilene, Texas. So we looked at Abilene, Texas, and we said, if somebody needed a triple bypass surgery in Abilene, there are two hospitals that do it. One of them is in the 31st percentile nationally in terms of quality, 0 being the worst. One was the 44th quality. So one was a D, one was a C minus. So, and their charges were both high because there's no competition, because they were very isolated. So given those choices, they really have very little to choose from. So what we did is we showed them, if you broaden that horizon to 100 miles, there's a place in Dallas that's in the 97th percentile for heart procedures, and their charges were actually less. So if you, as the employer or as the payer, want to make the decision, your employees have to stay in 25 miles, you don't care about the quality, you don't care about the charges, everything is based on proximity, then you're shooting yourself in the foot. And let's take that example a little bit further. Let's talk about global competition. If they didn't make Samsungs and LGs in Korea, if they didn't make Sonys in Japan, we'd all be watching RCA TVs. And Jeff, I'm sure you remember the old RCA CRT black and white with the snow all over the screen. We'd be watching those. If they didn't make cars, overseas, we'd all be driving Edsols. that would probably cost like $50,000. So global competition, and by global, it doesn't necessarily mean outside of the country. It just means traveling to Phoenix, traveling to Orlando, going to Houston. Okay, but it means traveling for care. Now, Kishore, this is I'm getting to your question. How do you, if the local providers just aren't competing, what do you do? Well, you give people the option to save money and drive an hour or two. Okay, pretty soon, what's going to happen is people are going to say, "Wow, we're losing business." Well, maybe it's because your quality is low and your cost is high. My middle son, is an economics professor, and long ago, he was really, really excited when he was getting his PhD, really excited to hear this theory. And one of his instructors was Milton Friedman's son, the last class he taught at not Fresno State, San Jose State, talked about how if you have a city and there's one heart surgeon, that heart surgeon can charge $100,000 for a triple bypass. All of a sudden, all the other heart surgeons say, "Wow, I can only charge $50,000 where I am." All of a sudden, you get a second heart surgeon. Then guess what? There's competition. They can only charge $65,000. All of a sudden, there's two more that come in. All of a sudden, they can only charge $50 or $40. So competition increases quality, decreases cost. LASIK surgery is a prime example. So you have to give the employees, number one, the incentive, and number two, the ability to travel, to say no to that local provider. No, your costs are too high and your quality is too low. I'm taking my money elsewhere. Pretty soon, those other surgeons will move into the area. That's the first question. The second question is also a great question. Critical illness insurance. I, myself, personally have $500,000 of critical illness insurance on myself. I'm originally from Canada. One of the people that I spoke to was actually the guy that developed critical illness insurance. He's a heart surgeon from South Africa. His name is, well, he's passed away a number of years ago, Dr. Marius Barnard. Marius and his brother Christian Barnard performed the first successful human-to-human heart transplant on December 2nd, 1967 in South Africa. In 1982, Dr. Barnard realized that he was preserving people's lives, extending people's lives. People used to have a heart attack and die. All of a sudden, he was extending their lives, but their economic lives were declining. He would see them for a follow-up visit, and they would be angry. And he'd say, "I extended your life. What do you have to be angry about?" "Well, I'm not disabled, so my disability insurance isn't paying. I'm losing wages because I can't work as much as I used to. I can't get the care that I want because I'm restricted to what the insurance company says." So he invented critical illness insurance. I agree with you. It is vastly underutilized. That's why I have $500,000. God forbid one of these 21 illnesses should occur to me. I want the ability to go wherever I want. I don't want my payer saying, "Yes, you can, no, you can't." So that's what I do to protect myself. And I think it's something everybody should have, critical illness insurance. So I agree with you 100% on that.
Very nice. And in truth, if you're remembering, and we can remember some of us, when you used to just be called hospitalization insurance. So really you were paying for everything out of your pocket. And then there was hospitalization. So what you're talking about, if and when and maybe something bad happened, I got a chunk of change, I can go where I want because I can pick up the odd doctor visit along the way. That's not going to hurt me. How many people, and I'll let you comment, I had a guy, and you'll appreciate this, that the fellow, I said, "Look, by us switching you over from, insurance to medical cost sharing, you'll now be a self-pay patient." And the guy started laughing hysterically. I said, "What's so funny about that?" He says, "Jeff, I'm already paying $1,300 a month. I got a $10,000 deductible. I'm already a self-pay patient." But look at the amount of money, because what if they only went to the doctor once in a whole year or whatever? They took the kids in for their, checkup before school. That's a lot of money to spend for a doctor visit.
Yeah, absolutely. It sure is. Yep, absolutely. Now, you reminded me of a story, Jeff, many years ago. Probably, I don't know, in like 1917, 1934, something like that. What we now call life insurance used to be called death insurance.
Right.
And life insurance agents said, it's really hard to sell death insurance. Let's rename it. Let's call it life insurance. Well, life insurance doesn't keep you alive, okay? It doesn't ensure that you stay alive. So the term is actually kind of inaccurate. Death insurance actually made more sense. They used to also have, as you commented, Jeff, sickness insurance. When you get sick, you have insurance, okay? Health insurance doesn't make you healthy. Paying that $1,300 a month doesn't ensure your health, okay? So by renaming it to something that was a little bit more warm and fuzzy, hasn't improved the product. It hasn't improved what it did. It didn't change what it did. It just gave it a nicer, more fuzzy name so that people didn't have to call it, hospitalization and sickness insurance or death insurance. But really, in essence, that's what it is. So once we realize that what these products really are, then we can start to solve the problem.
Yep, you're right. Just like when he was commenting that people don't know about that indemnity stuff, consumers will buy most everything that's appropriate if they're told about it. And that is a big challenge because the powers that be have a lot more money than you and I to spend to make sure that their message drowns out anything we could hope to say. But we're getting there. Getting there. Bob, I see you got your hand popped up again.
Yeah, I wanted to go back to, I think it was Kishore had the two questions, correct? Kishore?
Sure.
Kishore, I'm sorry. The first one was more about how do we get people to participate if they're not in network? And Ralph, you talked about, really a super option network. So I wanted to weigh in on that and then ask Ralph if I'm missing something. So one answer to the question is that in a traditional, well, let me back up a little bit. Ralph, a couple of times you've said either the employer or whoever the payer is. But in the world of direct contracting and reference-based pricing, fully insured contracts with small employers, with Blue Cross, Aetna, Cigna, United, they don't care about containing healthcare costs. They're not that interested in direct contracting. So I think this conversation, this whole presentation should be about employers who want to go to their employees and say, you used to have two options. You could go out of network and pay about 50% for that meniscus surgery. You can go in network and pay about 20% until you hit your out-of-pocket maximum. Or now we have this super option network. You don't have to do it. It's optional. You don't have to change the plan documents. You don't have to wait for open enrollment. You could just say, we now have a third option. And if you go to the Surgery Center of Excellence, not only do you get no copay or deductible, but we'll pay you and your spouse your hotel room for a night. And then when you get back, we'll put $1,000 in your next paycheck. But you don't have to. Right. You can still go to the local hospital. So that's what I just wanted this audience to realize, that this movement of reference-based pricing is a subdivision of the movement of direct contracting, where employers say, I'm going to start paying providers directly with a check and not go through any insurance code systems. And I'm going to create a third option, out of network, in the direct contracting network, and so that's the way you incentivize them. And again, it's all carrots, no sticks. It's optional, and you just steer your employees into that. So would you agree with that, Ralph? That's kind of what.
Exactly, Bob. I couldn't agree more. And that's what we call our bolt-on program, where we say, hey, look, if you want to use Blue Cross and pay the $3,500 deductible and stay in network, $7,000 now, go for it. Do it. Like, that's your plan now. That's what you've got. That's what you're used to. Not an issue. If you want to only pay $100 copay for that procedure, then you can use the bolt-on option, pay $100. And in some cases, we actually pay them because the savings are so great. So we actually pay them $100 reverse copay instead of them paying up to a $3,500 deductible. So that, I think we're talking about the exact same thing. We just call it a bolt-on program, but your word describes it accurately as well.
Thank you. That's great.
Ralph, that was extremely informative, and sadly we've reached the end of our time frame here today. We obviously can keep on going, and there was a odd question or two left over, but we'll have to save that for another occasion. So definitely want to thank you for today.
Well, thanks, Jeff. Thanks for having me, and thanks for everybody that participated. Some great questions. Enjoyed being here, and hope we can do this another time.
Definitely, we will. And on the way out, I got a couple little last minute messages. We want to entertain one of our other killer sponsors that we found, and this one is very appropriate timeline wise. Excuse me, I'm going the wrong direction. And we're giving this doctor's giving a free consultation with this code. But this guy solved all sorts of amazing things over the years, and here we're in this so-called COVID lockdown, and actually he's got some stuff they've actually solved that long time ago with SARS. And here's all the science behind it and everything else. Very, very interesting scenario. So definitely want to take advantage of that. Look for this recording coming out on Monday, like I said, and you'll find us on all these different channels like Brighteon or BitChute, like I showed, and also up on YouTube until we get banned over there too. So you might want to have this as the backup in case Ralph said something that was offensive tonight. But anyway, I appreciate you being here. So that was great.
Thanks, Jeff. Appreciate it.